Good afternoon, everyone. Am I well audible to everyone?
So, yes, Dr. Ali.
Yes, okay. Okay. So I think this is your one of the first classes in the FCPN. I'm really excited to see all of you here today. So today we'll start our first class, or we'll start a journey into the world of palliative care. I think pain is one of the main aspects of palliative care. That's what we usually see here. One of the most important aspects of palliative care also. So today, by the end of our time, we will have to gain new insights in how we can support our patients in managing. In this session, we will be talking about managing the pain. So I also want this to be an interactive session. So it would be great if you would respond to my questions, and it can also be. So we'll begin. So, what is pain? What do you think by pain? So, any of you guys have any answer? Okay, let's imagine ourselves in the shoes of any one of our patients. We'll maybe go through a story. We'll picture a scenario where we'll see Mrs. X. Mrs. X be for a checkup. So she's dealing with cancer. We'll just say an example. Imagine she's dealing with cancer for a few years. And today, when she came to the OP, she looks particularly worn out. She looks very tired, very full. But when we asked about her pain, she quietly says that it's pain, but you can see the discomfort in their eyes. So, in this situation, what do you understand from this scenario? What do you guys understand from this scenario? That we see a person, but they're saying I can manage. We'll see. Eh? But in her eyes, from her face, from her facial expressions, we understand that she's in severe. The thing is that pain is actually a very highly subjective experience. It's not just about the physical things. Maybe it could also be tied to her emotions. It could also be tied to worries about her family, even her spiritual concerns. Am I audible?
Now it's clear, but in between your voice was not clear.
Okay, okay. Please let me know if it's not clear, so I
Uh,
can just readjust my mic. Now
Now
also
it's
I think
clear.
it's not
Now,
clear.
now it's clear only. Now clear.
So I was saying pain experience can be only the patient can say how much distress she's in. That's the main thing. It will also be tied to her emotional, spiritual problems. She could be even angry to God that she has been religiously.
Dr. Ali, your voice is breaking.
After all our prayer,
Yes.
my
Dr. Ali, can you hear us?
Just it's not just the symptoms. In palliative care, it's not just the symptoms that we treat. That's what I was going to say. We treat the whole person. eh? We try to treat their psychosocial aspects, their spiritual concerns. We try to manage that, the physical problems, even the emotional problems as well. As this is the definition of pain, an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Maybe it could be there, it could not be there. If the patient says there is pain, we have to believe the patient, we have to manage the pain. It's a sensory, emotional, and subjective component. First, Dame Cicely Saunders, our founder of modern hospice movement, said total pain includes physical, emotional, social, and spiritual dimensions. So actually, you guys can be proud because Dame, the founder of modern hospice movement, Dame Cicely Saunders. So we'll want this key feature because pain is a very personal experience. Any physical cause, any bodily cause.
Sorry, Dr. Ali, still
Yes.
same, your voice is not clear.
Just a second. Maybe I'll just adjust this. How about now?
Yeah, now it's clear only.
It's clear. So I think it's reverberating, right? Just a second. Sorry. I'm sorry. How about now?
Now it's clear.
Now it's clear, I believe. Right?
Yes. Yes.
Okay. So nociception vs pain. There can be any pathological causes for pain. Maybe in some cases it could be idiopathic also. But we'll have to assess it and find out what's causing the pain. What's the root cause of the pain. As I said, influence of life experience. Even life experience also could influence the pain perception. The patient could be a well pain tolerating patient. They can adjust up to pain up to in a pain scale. When we are saying 0 to 10, maybe uh, they can bear a pain up to 6 or even up to 8 also. Some patients can bear the pain, but some patients, even if it's a 3 by 10 score for the pain, even though it's 3, we feel like maybe they can adjust or bear the pain, but for some patients that may be not the case. For some patients, only they'll get adequate relief only if it's 0. For some patients, it's not the case. It's actually just, as I said before, it's personal experience. But even though then we have to respect the patient's pain expression. Some patients may be severe distress, but they won't show it in their face. They may be in a calm, composing expression, but they'll be having severe excruciating pain. The only thing is that we have to believe what the patient says. Some patients may have less pain, but they'll express it severely. They'll be maybe rolling on the floor also, but we'll have to respect that. We'll have to help them. For non-verbal communication also, pain can also be presented. They can also express their pain through non-verbal communications, like they may be catching their stomach and lying down, maybe through crying. They'll express maybe through anger. We can't say. It's actually personalized, individualized. That's what we say. The concept of total pain, just as I discussed before, it recognizes the whole physical, psychological, social, and spiritual aspects. It's actually very important I would say it's important in all aspects of healthcare. But when we are saying this class is mainly in palliative care, so I would say it's a very important aspect in palliative care. As our beloved Dr. M.R. Rajagopal said, all pains are real, and pain can lead to more pain, both physically and psychologically. So we'll have to address all this. There is multi-dimensional approach. Maybe we can't do this alone. we'll have to need the help of a psychologist, a physiotherapist, maybe a social officer. All everyone should combine and work together to alleviate the patient's problems. Are you guys understanding me? Or should I just tone it down?
Yes, sir.
Can everyone hear me? I think I'm audible. Right now, I'm audible, I believe.
Yes, yes.
Okay, so we'll move on to the next section. So we'll explore different types of pain now. It could be nociceptive pain, neuropathic, acute, chronic. We'll see how there will be multiple ways a patient expresses their pain or they present to our OPD with pain. For instance, we'll take Mr. X, Mrs. X's example. Her pain might be, it could be, as an example, it could be a mix of sharp somatic frame pain from bone metastasis and dull. Since she's a fourth stage cancer patient, it could be a somatic pain from due to the burst of noxious stimuli by nociceptors. We'll see a little more in detail. So the process transduction, transmission, modulation, and perception of pain. I'll just show you a video on how this the pathophysiology of pain. You'll get a little more better idea by the video with the video. So when we A beta fibers, when the pain signals come through the first order neurons, it gets inhibited by inhibitory interneurons. When we give a small external pressure or skin rubbing or hot or cold packs or even tense, small vibrating machines, tense, we can, when we give that, the A beta fibers get activated and it in turn activates the inhibitory interneurons, which will help in controlling the pain. That's how. That's why when a child hits their head, we massage on it, we rub it, we give hot and cold packs. This is how the patient have a mild relief for the pain. So over time, the body's pain receptors become oversensitized. The sensitized nociceptors trigger the adjacent neurons, expanding the pain signals. As a result, the pain experienced become more severe and widespread. So, do you guys have any doubt? You can ask if there is any doubt, if you need some clarification. I believe I am audible right now. If you cannot hear me, please
Yes, yes.
me.
Yes, yes, you are audible.
So, is there any doubt until now? You can ask. There is anything you want to ask. These are the types of pain we just discussed before. Nociceptive pain, pain sensation resulting from injuries of tissues. That is somatic bone pain, soft tissue injuries, visceral injuries, or example, organ pain. The neuropathic pain, which results from nerve damage, could also be due to diabetic neuropathy. It could be induced due to chemotherapy. All these reasons can have all these reasons could be due to the neuropathic pain. Then allodynia, it's a pain from non-painful stimuli. Hyperalgesia is an exaggerated response to pain. Allodynia, what they usually complain is that while putting a cloth over their body or just while dressing, they have excruciating pain. Or when the fan is on, when the wind hits their face or when the wind hits their part of the body which is in pain, it exacerbates their pain. There won't be any painful stimuli, but they'll be in excruciating pain. They can't just have put on over, they can't use a blanket. It will exacerbate their pain. That is allodynia. Somatic pain, which is localized, intense pain that is often described as sharp, aching, or throbbing, accompanied by local muscle guarding or rigidity. Visceral pain, poor localized, intermittent, and cramping or colicky pain, may be accompanied by nausea or vomiting. Acute vs chronic pain. Acute pain is a short-term protective response to an injury or illness. It is typically accompanied by physiological changes such as an increased heart rate, increased sweating, pupillary dilatation as the body reacts to noxious stimulus. Chronic pain. Chronic pain, on the other hand, is a long-term condition that may persist even after the initial injury has healed. Unlike acute pain, chronic pain is often protective and can significantly impact an individual's quality of life, including disrupting sleep patterns and daily activities. So, for that, we'll discuss further cases. We'll see a scenario where we take pain assessment. Can you guys share the video that was shared?
Sure, sir, sure.
Okay. So what did you guys understand from the video? Was the audio audible? I mean, so was the video audible? Did
Yes,
everyone
yes.
listen to the video?
Yes, sir. Yes, sir.
So what you guys understood from this scenario? It's just the things that we discussed before. We have to understand, we have to take a good pain assessment, and we have to see what is affecting them mostly. It could, just as we discussed before, it could not just be her physical problems. It could be emotional problems, psychosocial problems. So it could be the way the doctors behave to them. Even that could increase her pain up to some level. So it is very important for reliable pain assessment. So what is the difference when a chronic pain patient comes or an acute pain patient comes? What is the difference when it comes to a chronic pain patient? So what do you guys think? What difference will be there if it's a chronic? For example, I'll say it could be diabetic neuropathy. The patient is in severe pain. So what will be the difference from an acute pain and a chronic pain? What do you guys think? When it comes to chronic pain, the chronic pain might be more consistent in nature. It would be less protective. The patient will have significant impact on his daily activities. His mental well-being will be affected very much. His familial surroundings will be in a problematic situation. But when it comes to an acute pain, they'll be in distress. But when it becomes chronic, all their daily activities get affected. They'll lose the quality of life they had. The main aspect in palliative care is to improve the quality of life of a person. It could be anything. We have to try to improve the quality of life for that individual, however possible it is. So we'll see. If, for example, patient X, the case we discussed before, the patient is in severe pain how will we assess the pain? How will we assess it? Pain assessment is actually our gateway to effective management. It is very important and primary, I would say. Tools like this numerical rating scale, Wong-Baker's rating scale can be used to assess the pain of the patient. Even if it's a patient who has no verbal communication, we can use Wong-Baker's pain rating scale, which will be easy in assessing the patient's pain. So from this, we can try to understand the intensity, nature of pain. What we actually use here is the PQRST assessment. So the PQRST, we ask them for the precipitating or palliating factors. What makes the pain worse? What makes the pain better? What gives them relief? Then we'll have to ask them about the quality of pain. How would they describe the pain? What does it feel like? Is it a numbing like pain? Is it a pricking like pain? Actually, we shouldn't give them options. We'll have to ask them how they can define their pain. Some would say it's a dull, aching pain. Some would say it's a pricking pain. It's excruciating, pricking pain. Then will have to ask them about the radiation. Is it in a single place or is it move around the body? For example, in patients with severe pancreatitis or CA pancreas, the pain can be radiated to their upper backs, their left and their bilateral shoulders. It can be radiated like that. So we'll have to ask that for paraplegic patients also. For patients with neuropathy also, the pain might be radiating. For IVDP patients, it might be radiating. The pain might be radiating from the spine to their lower limbs. So we'll have to ask them which side. We'll have to take a detailed assessment. The site and severity. Where is your pain? On a scale of 1 to 10, just as we discussed before, we can use a numerical scale here from 0 to 10. On a scale of 0 to 10, 0 means no pain and 10 means unbelievable, excruciating pain. If that's the scale, how bad is your pain? We can ask them to rate it. So some patients won't be able to rate according to this. So to that patients, maybe we can ask, is it a small pain? Is it a bearable pain? Is it a moderate pain? Or is it severe pain? These three scores, they can most probably, they can answer if it's a verbally communicating patient. Then timing and treatment of history. Since when did the pain start? How often do you get it? Is it a continuous type pain or just it comes and goes? What are the patterns of the pain? Is it a constant pain? Just as I said, does it come and go? So did he take any medications before for the pain or was it left untreated? Did that medication or did the medicine that was took for the pain, did it help? We have to ask all these things. So then we'll have to assess we'll have to take a psychosocial assessment, I would say. We'll have to find their familial history. We have to ask about their mental status. We have to even do a spiritual assessment. Is there something else that we can alleviate or is there something else that we have to look into to treat their pain? So this is the body chart we use in our hospital. We mark along with the PQRST, we mark where the pain is, which will be easier for us and the other coming doctors or also for the ongoing follow-up. This will be very helpful. We usually ask the patients if they can write or draw. We usually ask the patients to mark it in the body chart. Now the principles of pain management. So what are the principles of pain management? If it's a cause that can be alleviated or if it's a treatable cause, the first point is correct the correctable. If there is an underlying condition, we have to identify and address the underlying medical condition that is causing the pain whenever and wherever possible. Then non-pharmacological measures. We can use the non-pharmacological measures like TENS, just as we discussed before, hot and cold applications, relaxation methods to manage the pain, just as we saw in the video. We can ask all these things to the patients to alleviate their pain. Ask them what they used to do before, when before admitting or before seeing the patient, what they used to do to get pain relief. Some might say they would lie down, lie in a supine position. That will give them mild relief. Ask them to continue doing that along with the other managements that we are doing. Then pharmacological management. When it comes to pharmacological management, we actually use the WHO analgesic ladder for our appropriate medication management. We'll move on to that just a second. So when we come to the WHO analgesic ladder, it's a step-by-step process. For cancer patients, what we usually do is we start with, actually all patients we do this. I'll discuss further. We start with non-opioids, which could be, we can start that with paracetamol. Paracetamol is a good example, or NSAIDs. Brufen can be used, diclofenac can be used to treat mild to moderate pain. So, if the pain is not alleviating or if the pain is not adequately relieved, then we can move on to the mild opioids, like, for example, tramadol. That's what we usually give here. We can use tramadol, Ultracet, which is a combination of tramadol and paracetamol. We can use mild opioids with or without non-opioids, which will have an increased effect actually when we give adjuvants along with the medicines, adjuvants along with the mild opioids. So even then, the patient is not having adequate relief, then we can move on to the strong opioids. For mild opioids, we can use tramadol, tapentadol, codeine, etc. We can use that along with or without paracetamol, with or without NSAIDs, or without any neuropathic medications also we can use that. Then step 3, we will move on to the strong opioids. For severe pain, we can actually directly move on to the step 3 also. If the patient, we'll have to assess the pain. If the patient is a cancer patient, it's a very severe pain, we can assess that. It's a bone pain, very severe pain. We can directly move on to the step 3 for like morphine, fentanyl, methadone. If the patient has long chronic pain, coming occasionally, I mean, coming continuously, and morphine will have to take on a 4th-hourly basis. And there are multiple factors. If it's not, the pain is not alleviating with morphine, fentanyl, and all, we can move on to methadone also. Same with, as we said, with mild opioids, with or without adjuvants, with paracetamol, with brufen, with or without paracetamol, with or without brufen, with or without the neuropathic medications. We can be given, but there is no need to give mild opioids along with strong opioids. There is no action in that. Neuropathic medications as in, for example, amitriptyline, pregabalin, gabapentin, we can all give this to the patients with or without the opioids if required. So what is our target of pain control? Can we assure them, can we assure the patient of 100% pain relief? Can we do that? What do you say? Can we do that? The thing is that we have to remember that we treat the patient, yes, but it's not just the pain that we have to treat. That's why we also have to consider the non-pharmacological options, just as I said before. Maybe even a session of physiotherapy can help them. Maybe sitting with the patient and speaking with them can help them, offering them emotional support. Just as I discussed before. Maybe a session, just a session of sitting with him and speaking with him, offering emotional support it will help the patient more than what we expect actually. Every patient's treatment should be individualized, I would say. It should be as unique as the patient. So to achieve satisfactory pain relief, our primary goal is to ensure the patient experiences adequate pain relief, allowing them to rest, allowing them to move and function comfortably, to ensure pain-free sleep and rest. Maintain a pain-free state during sleep and periods of rest is crucial for the patient's overall well-being and recovery. Not just for the patient's overall well-being, even for the caregivers. The patient is in severe distress and if the patient is in severe pain, even the caregivers could not sleep. They would not be able to sleep. They will have severe distress. They would not be able to, if they don't get adequate sleep and adequate food, how will the caregivers look after the patient? That will also affect the caregivers even. So we'll have to ensure a pain-free sleep for the patient actually. So we'll have to, for when we give morphine, actually we give morphine on a 4th hourly basis since the half-life of morphine is around 4 hours. So we give them round the clock. So when at night, what we do is usually if it's we have to give it at 10 p.m. and 2 p.m. We have to give 5 mg of morphines 4th hourly. What we do is we double the dose at 10 p.m. and we give them 10 milligrams of morphine at night. Why? To ensure them pain-free sleep and rest. Also, we will have to set a realistic expectations. It is very important to set realistic expectations for pain management outcomes, ensuring the patient understands the limitations and potential side effects of the treatment. So, what think about how our understanding of pain and tools we've discussed. So, what do you guys understood from this class? So how can you make a difference in your patient when they come to your OPD, when they come to you for help? Now, as of now, what change would you have when seeing the patient? What are the key takeaways? That's what I was asking. What are your thoughts? Think about how our understanding of pain and the tools we've discussed, which could make a difference in their lives. What questions would you ask again, or what will you think about when a patient suffering in pain comes to you, or when you see a patient like that? What all thoughts will you have? How will you try to alleviate the patient's suffering? Am I audible? Can everyone hear me?
Yes, you are audible. Anybody have any answers? You can unmute yourself and talk, or you can put your answers in the chat box.
Does anyone have any doubts? Okay, the pain man when in palliative care, I would say in only in palliative care. Actually, it's true everywhere. When it comes to pain management, it's actually an ongoing journey, which requires compassion, which requires attentiveness, I would say, and our willingness to see more than just the physical symptoms. That's what we should see. We should also focus on the patient's emotional aspects, emotional pain. It is as important as the physical pain. So I would also ensure regular follow-ups for the patients to adjust the pain management. If a patient comes with a chronic pain, their pain medications must be adjusted according to the individual. It is also very much individualized. We'll have to adjust it now and then, and we'll have to do regular follow-ups and find out if the patient is getting adequate relief. What we believe is that there should not be a patient there is no need to suffer with pain. We have the medical technologies have advanced, so there is no need for a patient to suffer. So we have to make sure the medicines are in regular supply. The patient is having a good quality of life. We have to ensure that. Uh, the thing is that we should be willing to see more than just the physical symptoms. So key takeaways are comprehensive pain assessment, understanding the concept of total pain. That's what we've discussed today, and a compassionate approach, which are crucial for effective pain management in palliative care. And the holistic approach, we said we have to see we have to address the total pain. We have to address the physical, emotional, social, and spiritual aspects of pain, which is essential for improving the quality of life for the patients. Then, as I said, regular ongoing evaluation, regular follow-ups, regular monitoring, and adjustments of pain management strategies, which is very much essential. So, is there any questions?
Thank you, Dr. Ali, for the wonderful session. Anybody have any doubts or any clarification?
Is there a case presentation after this?
Yes, yes. We have one case presentation, but before that, if they have any doubts, we can clarify it and then
Yes,
go to
sure,
the
sure.
case presentation.
Please ask if you have any doubts.
I know in between the voice was not clear sometimes, but I think most of the things you can able to hear. So I hope these all you all are get an idea about pain. So before moving on to the case presentation, I would like to highlight few things. We all nurses, as I mentioned earlier, we are spending more time with the patient, and also we have a good nurse-patient relationship because of that. So we are the responsible person. We are the apt person for that assessing the pain. So that is very very important. So because uh, we know pain is a subjective symptom. Without patient says we can't understand where they have pain or not. So we have to believe the patient words. That is one important thing because this is a subjective experience. So we have to ask them whether they have pain or not. See, if they have pain, you have to understand that what are the different types of pain. Nociceptive pain and neuropathic. So, nociceptive pain and neuropathic pain, you have to understand that because we have to treat differently because nociceptive pain have different medication and nociceptive pain have different. So, we have to understand the type of pain. Okay, so nociceptive pain and neuropathic pain are the major the pain we need to understand. Two different types of pain: nociceptive pain and neuropathic pain. Okay, and after that we have to understand that how to assess the pain. SDPQRST. SDPQRST. What is yes? Yes is site. Where is the site of pain? Whenever you have seen a patient with pain, you have to try to understand the pain, how to assess the pain. STPQRST. S is site, D is duration of pain. Then the rest of the things, you can see this slide. P is provocative factor or palliative factor. And quality, what is the type of pain and radiation. The pain is radiating from where to where. If there is any radiating pain there is a chance of neuropathic pain because of the nerve compression or nerve injury. There, usually the patient will say it's a radiating pain, right? And then site and severity. So site we already covered, and severity. Severity, you can ask the patient. 0 to we usually use 0 to 10 scale. 0 is no pain, 10 is worst imaginable pain. So we can ask them 0 to 10 scale, what is the number of score you can give for your pain. Then based on that, we can treat. And the last one is temporal factor. So whether that pain is affecting their sleep, affecting their that food, these all things there. So we have to ask them. So if you ask these things together, definitely you won't miss anything. You will get a good idea about the patient pain, and also you have to think about the total pain concept. So who brought the total pain concept? Dr. Dame Cicely Sonder, who was the founder of palliative care. She brought out the concept of total pain. So we have to keep it in mind all the time, because if they have a psychosocial spiritual issues there, their physical pain intensity will increase. So we have to give a attention to that aspects also. We all are focusing on the physical aspects, but at the same time, if they have at the same time, we have to understand that if they have psychosocial spiritual issues there, their their distress will increase. So we have to address that part also. Then only your medicine will get benefited. So that is very, very important. The rest of the part that Dr. Ali was described well, and if you assess well, you can able to make a good plan. So that plan will help the patient. So if there is a psychosocial issues there, then you have to think about the teamwork. You have to try to include a social officer, social worker, or a psychologist into that patient care and explore the psychosocial issues and ventilate their feelings. And if they need, if you can act, you can give some kind of support. Definitely, we can give psychosocial support. So at the same time, if there is a severe pain there, try to relieve their severe pain, then you can look into the other aspects. So we have to keep it in mind, the total pain aspects all the time. So we need a holistic approach, and we need an empathetic mind. What is empathy? Putting ourselves into their shoes, right? So is what is the role of a healthcare provider? So our role is to mitigate suffering. So we have to think from the patient side, and always you have to think about the total pain. Okay, thank you. I think we can move on to the case presentation. Any other questions? Any other questions? I hope it's clear. Any questions or clarification? Anybody? No. Okay. So Bhagyashree, ma'am will be presenting a patient story today. It's Bhagyashree, so to you.
Um, Sir, can you please stop share? Hi, Gisri, are you there?
I am not sharing, as it seems. Am I sharing?
No, sir. No, sir. No, it's okay. You have stopped sharing. Hi, Gisri. Hi, Gisri. Can you please read out? I can see you on the screen, but you are not responding. Hi, Gisri, please unmute yourself and read out. Can somebody else? I think Bhagyashree is not there. Can somebody else read out the case? Can someone volunteer? Sundaravalli, can you?
Ma'am, Sundarivalli ma'am, could you please read out this patient story?
And the patient
Yeah,
said
ma'am. My patient,
yes.
hello,
Okay, so
hello.
Yes.
both of you have started to.
Yeah. Okay.
Anybody can. Sundaravalli ma'am, go ahead.
The age of the patient is 22 years. He is a male patient, and the diagnosis was sickle cell anemia with recurrent vaso-occlusive crisis. It is. The present complaints of the patient is admitted in palliative care ward for supportive care, and present chief complaint of the patient is having limb and truncal pain, crisis weakness, pain in the leg, arms, then fatigue, severe wasting, muscle wasting. So the complaint is truncal pain, crisis, weakness, and the patient's arms are getting sweaty, and severe wasting, muscle wasting. These are the chief complaints they told. The patient was initially admitted in General Hospital, Varda, and the symptoms are lower limb pain and severe joint pain. There were no symptoms of diarrhea, skin rashes, herpes lesions, difficulty and breathing, chest pain, vomiting, and pain in the abdomen are present. Or not in the patient. On examination, the ECG was taken and the sodium potassium level was checked and the complete blood test is checked. Liver function test also it is checked. The renal function test also they have undergone. Then gram staining they have done. Then hepatitis antigen, surface antigen has been done for the patient, and the urine examination. And the patient has undergone reticulocyte count and APTT, amylase, serum, lipase and serum, LDH level should be checked for the patient. The treatment option, if you are seeing on examination, the patient was here severe vaso-occlusive crisis with the pain affecting multiple joints, so including leg, knee pain, and the shoulder also it is affected. Both the shoulders it is affected. So the vital signs was checked in that the pulse is 84 beats per minute, and the blood pressure is 130/70 mm of mercury, and the SpO2 was 95% for the patient. So the patient was treated with a morphine, that is infusion of 2 milligram per hour for 72 hours is given for the patient, and injection pantoprazole 40 milligram OD is given for the patient, and injection emisset was given for the patient because the patient is having vomiting, and injection 14 was given for the patient. The NOAC, if it is needed, is given for the patient. The tablet ibuprofen was given by BD, and folic acid is also given for OD because the patient is having sickle cell anemia. And the Zinco-Lac also is given for the patient as a OD drug, and the tablet morphine was given 15 milligram. 4th hourly it is given for the patient. And a tablet hydroxyurea also it is given for the patient. The psychosocial aspects which we have seen, the patient was initially and managed with the supportive care, and later spent 3 weeks in the palliative ward. His family members are actively participated in his care and assisting to the nursing staff. So the medication during discharge, I think it is given for the patient. Tablet folic acid OD is given. Tablet hydroxyurea 1000 milligram is given for the patient, and a tablet Zinco-Lac OD is given. Tablet morphine 15 milligram 4th hourly it is calculated and is given for the patient. The concerns has to be discussed here is the patient is unable to move. He is cooperative for anything. The next one is the patient was initially managed with supportive care, and later the patient spent 3 weeks in the palliative care ward. His family actively participated in his care, assisting the nursing staff, and the patient is under the physical therapy. The patient would follow normal commands, then speak and swallow, but remain unable to sit, stand, or walk. So the patient is immobile. The case summary, the patient was initially admitted to the General Hospital, Varada, with the symptoms of lower leg pain and the pain in the lower limb. The oral comments, there was no symptoms of diarrhea, skin rashes, herpes infections, and breathlessness. And the patient background, the patient is unmarried, lives with his mother and father and work as a daily wages as a laborer in the local area. So the discussion point is you have to improve the quality of the life. You have to provide relief of life, provide support to the patient, affirm life is provided through configuration with the disease modifying therapies whenever it is needed, provide support to the family and caregiver during the patient illness and their own bereavement.
Thank you, ma'am. Thank you very much.
Thank you.
Yeah, so I think this presentation is clear to everyone. So if anybody need any more clarification, anyway, Bhagyashree ma'am is not there, but even then we can able to discuss. No, so this is a patient story. Any clarification needed? Do you think any more clarification needed? Anybody? Uh, could you please switch on your videos? I would like to see you all.
Patient can't able to walk normal, so we can refer the patient to some other referral areas to get the walker like that.
Yeah.
Refer the patient because the patient is having weakness and also the patient is having fatigue also. So whatever medications if we are giving, patient is having sickle cell anemia. So it is very difficult to walk. So for the mobility, to improve the mobility, we can provide some walker like that.
Yeah. So
We can give for the patient.
thank you for saying this. Anybody have any different opinion or any other answers? You have to think about the patient side. You have to put yourself into that place and think. So today we have learned about the pain assessment, right? So here no proper pain assessment is there. That we need to do. So from that we should have an idea about the pain, right? So now this patient is on morphine, but we don't know where is the pain at all. So what was the score? Is there any intermittent pain? Is there any other problem? Is there any the temporal factors? Nothing is there. So we need that for management of pain. Definitely, this patient is not able to walk. If there is a possibility there, we have to identify the cause first before that giving wheelchair or before giving walker. You have to identify the cause. If there is any treatable cause there, definitely you have to treat the cause, treat the underlying cause. For example, if there is any bone metastasis there, is there any role of radiotherapy there? You can send the patient, refer the patient to the oncologist and see. If it is not possible, then you can think about the other option. Definitely, I agree, ma'am. You have to think about that. We have to improve the patient's quality of life. If he can able to walk somehow, we can provide a walker or a wheelchair. So, any other opinion, Dr. Ali? Anything you want to add? So the case presenter is not here, but anyway, we are discussing.
As shown in the discussion points, the important point is to improve the quality of life of the patient. If, as the doctor suggested, if referring the patient will obviously improve the quality of life of the patient, we can obviously do that. And also, if the patient is in severe pain, the most important thing is to alleviate the pain immediately. As what we usually say is, we should address the patient's pain within a matter of hours, or at most until the next day, the patient's pain should be managed effectively, at least for the time being. Then we'll have to see what can be done for the chronic problems. That's it, I think.
Okay, Dr. Ali. So we here we have to think about the total pain concept here. So here is a 22-year-old male was suffering with cancer, right? We have to think about his school life, his friends, these all things. These all will be affecting this person emotionally. He will not be able to go to the college or go to work. These all things will be affecting. And sometimes social problems will be there. And spiritually also, why God punished me like this? Why me? What? Why this happened to me? These kind of spiritual questions is also there. So what is the answer? So at least we can listen. We can sit down and listen. If he can able to explore her emotions, if his emotions, so definitely he felt like some kind of mental relief because someone feels a bad emotional things. So if there are the person to sit nearby and listen their worries, definitely they can able to explore it, and definitely they will get a good mental relief. Here also, do one thing, if possible, sit near to him and listen. And if possible, you can arrange whatever he likes because we don't know whether there is any metastasis or not. If there is any metastasis there, so most probably he is living very short time. So if he need anything, we will arrange. So we will give a proper support, and also here his parents and relatives are very good relation, very they have a good relationship, but at the same time we have to understand that what is their understanding about the prognosis, whether they are that understand about the prognosis or diagnosis, so that also we should know. So that is also the second important point here. We have a session on communication. That time we will we will more listen that part because that time, and also breaking bad news. If there is any the patient is not know the disease and the prognosis, definitely we need to convey the bad news to the patient and relatives, but there is a protocol, so that we will discuss later. And also for the management part, we have two sessions. That time we will discuss more because sorry, my voice is clear to everyone.
Is the voice clear?
Anybody? It's clear.
Yes.
Okay, thank you. So we have a two session on management of pain. So that time we will discuss more about that pain. So today Dr. Ali had discussed about the WHO analgesic ladder. So the WHO analgesic ladder step 1 and 2 we will discuss the next session, and the opioid will be session where we will have an one session for that and early for that also. That time we will look into that part. But today what we have to understand is we have to understand the total pain concept, and also we have to understand the assessment of pain, how to assess pain, what is the importance of numerical pain rating scale, and we have to understand the severity of pain. So based on the severity of pain we have to treat, right? We have to choose the medication. So for that we have to understand the proper history of pain, so that we have to keep it in mind, whether what kind of pain, the types, these kind of things we should know before managing the pain. So that's it. Any other things you want to add? Anybody? So the main aim of all of you know the main aim of palliative care is to improve the quality of patient and their family. And the second most important aim is to relieve pain and other symptoms. If we can able to relieve their symptoms, definitely we can able to improve the quality of life of the patient and the family. So that's you have to keep it. So if you don't have any question, we can wind up the session. Dr. Ali, can we wind up?
Yes, ma'am. Yes, yes. I think so.
Okay, thank you.
There are no any other doubts.
Thank you, Dr. Ali. Thank you, Shiba ma'am, for the facilitation. Thank you, Bhagisri, for sending us case. Thank you, Sundarvalli ma'am, for presenting it confidently. Thank you. I thank all the participants for being attentive and you were wonderfully present throughout the session. Okay, see you on the next session. Thank you.